Peace. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Welcome to the 9-9 portal has opened up along with the full moon is flowing through Pisces too, right there with Neptune and Saturn. So, yeah, it's that time. We just completed chapter 11 in the last reading, and in this reading, we will start at chapter 12, page 197 of Clinical Application of Respiratory Care. I'm your moderator and narrator, Uriel Riley. Thank you so much for being here in this beautiful 9-9 portal reading with us. Hi, it's Heart Love. All right, so chapter 12, Chest Physical Therapy. Welcome, YouTube. Peace. All right. 197 at the top. An integral part of respiratory therapy's recent advancement has been the adoption of chest physical therapy techniques. These techniques have enjoyed much earlier and wider acceptance in Europe than in the United States, where chest physical therapy remains a relatively unknown mode of treatment. There are numerous reasons for the slow acceptance in the United States, not the least of which is sparsity of qualified individuals for teaching. The past 5 years has seen a great gain in the utilization of chest physical therapy in large teaching centers. Most of this has been due to the availability of skilled chest physical therapists in aggressive respiratory care programs. A deterrent to widespread acceptance is that physical therapy and respiratory therapy are separate allied health fields. There is a great reluctance on the part of some physical therapists to view these modalities as an integral part of respiratory therapy. Experience demonstrates that a team approach between respiratory therapy and physical therapy results in maximum patient benefit. Physical therapists must have a basic knowledge of respiratory therapy to appreciate and understand the role that chest physical therapy plays in bronchial hygiene and ventilation. On the other hand, respiratory therapists must be familiar with chest physical therapy techniques and be qualified to deliver such therapy. It appears inevitable that the majority of hospital chest physical therapy treatments will be provided by respiratory therapists since the techniques are commonly used in conjunction with inhalation therapy modalities and are required in intensive care 24 hours a day. The role of the physical therapist is primarily one of supervision, teaching, and evaluation. This chapter is limited to a superficial overview of chest physical therapy as it pertains to respiratory therapy. For more detailed and in-depth information, the reader is referred to other texts. Goals of chest physical therapy. Chest physical therapy is a series of manipulative techniques designed to prevent pulmonary complications and improve function in acute and chronic pulmonary disease. From the viewpoint of respiratory therapy, it seems appropriate to classify the goals of chest physical therapy. 1. To prevent the accumulation and improve the mobilization of bronchial secretions. 2. To improve the efficiency and distribution of ventilation. And 3. To improve cardiopulmonary reserve using exercise techniques to promote physical conditioning. Peace, highest heart love. Welcome. Peace. Thank you so much for reading with us live in this peaceful part of YouTube where we read books and learn from masters. We're at page 198 of clinical application of respiratory care. All those respiratory techs and those aspiring to take the MCAT, we're giving the information to you, thousands of dollars of information for free, right here in this peaceful, quiet part of YouTube. Thank you so much for being here and reading with us. All right. Chest physical therapy techniques may be classified in three categories. One, techniques that promote bronchial hygiene. Two, techniques that improve breathing efficiency. And three, techniques that promote physical reconditioning. Physical reconditioning is discussed in Chapter 32. Techniques promoting bronchial hygiene. Bronchial hygiene has been defined as the maintenance of clear airways and the removal of secretions from the tracheobronchial tree. The mucociliary complex and cough mechanism can be aided by techniques such as aerosol, IPPB, and 1. Postural drainage, 2. Percussion and vibration, and 3. Coughing assistance. Postural drainage. The disease mucociliary escalator is greatly enhanced when aided by gravity, i.e., mucus drainage of a lung segment is facilitated by body positions that allow mucus to flow in the direction of gravity. Obviously, postural drainage must be based upon a firm knowledge of tracheobronchial anatomy. Since branching of the tracheobronchial tree is variable and complex, practical postural drainage positions are best limited to areas of lung that commonly retain secretions. Lung segments. Bottom of the page, 198. We are now in chapter 12. Yes. The highest heart love. Thank you for reading with us. Lung segments. As illustrated in figure 12.1, the upper lobes are composed of an apical, anterior, and posterior segment plus a middle lobe. The linguala is considered a left middle lobe since the location and direction of the middle lobe bronchus of the lingular segmental bronchus constitute a mirror image of the right middle lobe bronchus. Although there are more precise anatomic descriptions of segments and subsegments available for all practical clinical purposes, these four segments are the ones commonly involved in upper lobe disease. The lower lobes have four segments: superior, anterior basilar, posterior basilar, and lateral basilar. The posterior basilar segment is the largest, encompassing at least half of the posterior chest wall and resting directly on the diaphragm. Figure 12.2 demonstrates that the superior and posterior basilar segmental bronchi do not have the advantage of gravity for drainage in the usual hospital bed positions. This undoubtedly a major reason why these particular segments are most commonly involved in atelectasis and pneumonia. Topical landmarks for locating these lung segments are depicted in Figure 12.1. The major fissure or oblique fissure separates the upper and lower lobes. The right middle lobe is separated from the upper lobe by the minor fissure. And here we go. This is Figure 12.1. Peace, highest heart, love. Thank you for being here with us and reading. Here we go. Figure 12.1. And what it has is you'll see the darker areas are the upper lobe. The middle sketched in dot areas are the middle lobe. And the empty looking areas are the lower lobe. Thank you for the likes and subscribes. We're pushing towards 1,000 subs reading books here live on YouTube. Gratitude, highest heart love. Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. This is the second edition, 1979. Those looking and inspired to take the MCAT, we're here for you, giving you the information for free right here on YouTube. This peaceful place where we learn from masters and read masterful books. So thank you so much for subbing and liking. Okay, so it says 12.1. Schematic representation of lung segments most commonly requiring bronchial hygiene therapy. Figure 12.3 illustrates the basic positions for drainage of the most common segments demanding postural drainage. These positions are essential for respiratory care practitioners to know and implement. All right, so here we go. This is figure 12.2 and 12.3. And so what it is showing is the positions in the bed and basically how the drainage position comes from that. So here we go. Page 200. We made it to 200. All right. So bronchial hygiene still, and we're in section 3. So here you go. It has an A and a B, as you'll see. All right. We're in the third section of this book, which is bronchial hygiene therapy. So I'll read it to you now. It says 12.2. Common body positions for ill or convalescent patients. A represents the common hospital bed position. Note that the shaded segmental and subsegmental bronchi of the posterior basilar segments of the lower lobes have no gravity drainage. These are the areas of lung most commonly involved with atelectasis and pneumonia in the acutely ill patient. B represents the absence of gravity drainage of the apical segments of the lower lobes in the supine position. Remember, supination or supine is when the palm is going to be facing up. Okay, so that's how we look at that. Pronation is when you're down, when the palm is facing down. So that would be when your face would be facing the ground or the bed. Okay, there's now supination, you're facing up. Pronation, down. All right, just wanted to clear that up for you. It says common body positions for ill or convalescent patients. Yeah, read that. So you see that in A, they're sitting up. Okay. And then down here on B, they're completely flat. All right. And on 12.3, it says common postural drainage positions for A, posterior basilar segments, B, middle lobe and linguila, and C, the apical segments of upper lobes. So, as you see, this is the common way to let it drain in those positions. A, they'll be tilted down, okay? And B, they're on their side and tilted down. And then C is you'll see them sitting up. Thank you so much for reading with us, going through this information so we can help others. If we see them having respiratory problems, we can get them into these positions so that they can breathe better. Hi, it's Heart Love Dan and Jamie. Thank you so much for being here and reading with us. We are in chapter 12 of clinical application of respiratory care and chest physical therapy. So, page 202 at the top, clinical indications. Peace. Hi, it's Heart Love YouTube. When normal bronchial hygiene mechanisms malfunction and secretions are retained, the patient becomes a candidate for postural drainage therapy. Diseases often requiring postural drainage include, but are not limited to, bronchial ectasis, cystic fibrosis, chronic obstructive pulmonary disease, COPD, acute electasis, lung abscess, ventilator care, and pneumonia. Postural drainage may also be required for post-operative patients and patients who have been on prolonged bed rest. There is always potential for contamination of the opposite lung when secretions are mobilized in unilateral disease. A general rule of postural drainage therapy is that care must be taken to assure prophylactic drainage of the opposite contralateral lung following therapeutic drainage of the disease side. Lung abscess is a collection of purulent material or pus. That's what it's called, right? Within lung parenchyma. The epiema is a collection of purulent material within the pleural space and may contain as much as 4 to 5 liters of pus. Postural drainage may result in the patient drowning in the pus or contaminating the opposite lung if bronchial drainage is established. An epiema must be surgically drained prior to the application of chest physical therapy techniques. On the other hand, lung abscess is usually drained best by appropriate chest physical therapy. Precautions. We're at the middle of page 202. There are several precautions which must be considered when applying postural drainage. Position change may be a significant physiologic stress to the cardiovascular system, especially in critically ill patients. Further, a head down position may diminish venous return from the head and result in increased intracranial pressure. It is best to avoid head down positions in postoperative neurosurgical patients and in patients with known intracranial disease. Postural drainage positions must not place stress on healing tissue, e.g., patients with recent spinal fusion or skin grafts. Postural drainage techniques must be weighed in terms of the potential benefit versus potential risk. In the final analysis, the decision is based on the therapist and physician's clinical evaluation. Chest percussion, figure 12.4. The technique of chest percussion is most often used in conjunction with postural drainage to loosen adherent bronchial secretions. The object is to have cupped shaped hands clap the chest wall, trapping air between the hand and the chest wall. The sudden compression of air produces an energy wave that is transmitted through the chest wall tissues to the lung tissue. This energy wave will theoretically loosen adherent mucus plugs and allow better mobilization of secretions via gravity and coughing techniques. The procedure is performed by rhythmically and alternately striking the chest wall with the cupped hands, producing a loud clapping noise without pain, discomfort, or bruising. Bony prominences, the clavicle, spine of the scapula, and spinal column, and female breast tissue should be avoided. Chest percussion is an excellent adjunct to bronchial hygiene therapy and is usually performed in conjunction with postural drainage. Highest heart love. Thank you so much for reading with us. Oh my goodness. Highest heart love. Yes, this is the smart part of YouTube. So we have the vocabulary to understand this information. We are not, with those other people. We let them run in and out, but they're low level. We're super high level. And so light attracts everything. That's what you have to remember in being a light worker. Light attracts everything. And that's why you have to know how to protect your peace. See, I'm a master fitness trainer. I protect my peace all the time. You know, people outright fear me when I walk down the street, especially if they don't know me. And that's because of my posture. They know I'm the dominant being on this planet. And so that's why it takes a very strong back to be a healer, because you have to take on everything around you sometimes. And we always come out winning. That's because the forces that we have working with us. So we discard anything that's not beneficial to the human race. And we bring the light by being that benefit. Care and judgment must be exercised when a patient is fragile or brittle. A skilled therapist can administer chest percussions to patients with brittle bones or fractured ribs. However, this takes great expertise and must not be done by the occasional therapist. In general, hemorrhagic hemorrhagic conditions, fragile bones, bony metas, metastases, and undrained empyema are contradictions to chest percussion. The procedure is usually avoided in patients with resectable tumors of the lung, so the tumor spread is minimized prior to surgery. And so here's figure 12.4, principle of therapeutic chest percussion. And it's showing the cupped hands, creating the air vibrations and how to, you know, just little percuss onto the chest and area. It says the vibrations that transmit to lung tissue, and see the text. And of course, that's what's happening when we are Putting the hands down. There you go. Thank you so much for reading with us Clinical Application of Respiratory Care, MCAT level book, highest level vocabulary. Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout combined to write this. It's the second edition. All right. Page 204, chest vibration. The technique of chest vibration is accomplished by placing the hands on the chest wall and producing a very rapid vibratory motion in the arms while gently compressing the chest wall. A skilled therapist can develop a vibratory frequency in excess of 200 per minute. This becomes an extremely effective means of mobilizing secretions toward the gravity dependent major airways in conjunction with postural drainage and following chest percussion. Chest vibration is performed during exhalation, following a deep inspiration, and is very effective adjunct to IPPB therapy in the intubated patient. Highest heart love. Thank you so much for being here. Thank you so much for reading with us in this peaceful part of YouTube where we read books and learn from masters. I'm Master Uriel Neville Riley. We appreciate you. All the book readers, all the authors out there, and the nurses and doctors, and all those inspiring healers. We love you here on this peaceful part where we read books and learn from masters. Thank you so much for being here and reading with us. So, we're at the middle of page 204, and we'll close out on this last paragraph. Cough instruction. Gratitude. We're pushing towards 1,000 subs where we read books in this corner of YouTube. So thank you so much for enjoying the piece with us. Hope all is delighted where you are and that you are manifesting and pulling it in from this 9-9 energy portal that's been opened up with the full moon. Cough instruction. Cough instruction is a simple technique requiring a thorough understanding of the normal cough mechanism. Chapter 8. The importance of a deep breath, the glottis, and the abdominal muscles must be appreciated. A patient receiving cough instruction must first be taught proper breathing techniques. A simple technique is to have the patient take several deep breaths and then a maximum inspiration, which he or she holds for a count of 3. After mastering this maneuver, he or she is taught to forcibly contract his abdominal muscles on the count of 2 and expel the air by opening his or her glottis on the count of 3. 2 coughs in succession may also be tried as an aid to mobilize the secretions. Cough instruction is useful in conjunction with all respiratory therapy modalities and with postoperative abdominal and chest patients. A painful incision will limit the willingness of the patient to cough. It is helpful to have the patient cuddle a pillow to his abdomen in a sitting position or for the therapist to support the incisional area with slight hand pressure. These maneuvers decrease the need to tighten abdominal muscles, the procedure that produces most of the pain. In patients with spinal cord injury or disease, the abdominal musculature may be severely weakened. It is often helpful to apply an abdominal binder or hand pressure to provide support. Compressing the The abdomen at the end of inspiration will help to increase intra abdominal pressure and therefore increase the cough effectiveness. Knowledge of the cough mechanism and the muscles of ventilation makes cough instruction an extremely simple and effective method of improving bronchial hygiene. We'll pause right here. In chapter 12, chest physical therapy, we still are in section 3 of bronchial hygiene. We're at the bottom of page 204 when we reconvene. Thank you so much for being here, for being with this is what, 32. Yes, this is the 32nd edition of reading Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Hi, it's Heart Love. Thank you so much to all the book lovers community, all the readers, all the light workers and healers. We love you so much. So, cheers to you, starting another chapter. Cheers to us, starting a new day. Some love water to all of you as we stay this peace. Thank you, thank you, thank you. I love you. Mm. I love you. I love you. I love you. Gratitude. Thank you so much for the likes and subs. Oh my goodness. Oh my goodness. Much love. Thank you so much. All the beautiful light workers. You are doing it. We're doing it. Helping to heal the world. And now it's Tuesday. So, we have a great meditation coming up. Thank you so much for being the lights of the world. We just destroy all the demons out there consistently every day because we are the light. So thank you so much for slaying all of the evil out there. It will never be able to stand in our light. That's why you'll see people come into this channel and go out and leave and come back in. It's because they're erratic. They have no control. They have low vocabulary, so they can't understand the information, and they're looking for something to disrupt. But we shake it up. We shake it up. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Highest heart, love. Thank you so much for being here. Remember, there's no skipping levels spiritually. There's no skipping levels. That's it. Simple and plain. Don't do drugs. Don't be mean to people. Be kind and gentle. Love one another and lift one another up, right? Now, I have super abilities, so I've learned that lesson a long time ago. I've never had a surgery. I've torn almost everything and every ligament from my elbow and biceps just recently, knees, ankles, healed every part of it. That's why you give yourself the grace, you know? It's most important that you love yourself. When you love yourself, you're going to do what it takes to master yourself, like we do here on this channel. I'll give you the information so that you can master yourself. Maybe one day you'll be able to climb mountains. You know, I've already climbed multiple mountains. That's what makes me the supreme elite being that I am, because I've never given up. And I use my powers for good. Heal the people. Don't do drugs. Love one another. Be kind to yourself. Yes, be kind. You can do it. I'm so great at being a mentor. So, y'all have questions, just throw them in the chat sometime or send me an email. I'll answer them the best way that I can. You know, being this high level, I've been told to give this information away for free. Yeah. I've already trained athletes in all different types of countries and on different continents. Most of you will never get there. But that's why I'm here now, to help give you encouragement to keep going, to know that you can do it. You have to want the best for yourself, and it will show in your world. It will show. I love you. I love you. I love you. And you know, I love myself. Y'all have a wonderful, wonderful day in this 9-9 portal. It's opened up. Remember, stay focused on the greatness that you want. Draw it in, right? In meditation, we're releasing anything that we don't want, any doubts, any worries, right? Focus the mind. We intend the mind, and you'll get everything you want. Eyes, heart, love. Peace, peace. I love you.